All right, well, welcome to this pharmacology drug class review on the category of drugs, anti-diabetic medications. We're going to give a specific focus on the sulfonylureas in the management of type 2 diabetes. Now, this drug class has been a part of treatment options for type 2 diabetes for my entire 30-year career in healthcare. And while the first generation agents came out in the 1950s, the current second generation agents made their way to the market in the 1980s and are still here today. Yes, commonly used, but still an established treatment option for type 2 diabetes that you must know. All right, with that, guys, I'm Dr. Busti. Thank you so much for joining me on This Is Why, a show dedicated to helping us as healthcare professionals understand why behind the things that we do. And that includes understanding pharmacology and the drugs that we use every day. Because when we understand why, it makes the how easier, and that mechanism starts to illuminate and make sense of the therapeutic effects, but also side effects, which this class has issues, also dictates and governs our monitoring parameters and our counseling points. So, just like with all the drug class reviews, we cover core content. We're going to hit those agents, indications, what is the net benefit, dive into the pharmacology, and then get into clinical knowledge, pearls, application to make it kind of come alive for what you're going to see in real world practice. Now, we're not talking about first generation agents. They're there from a historical perspective in some of the tables that I provided you, but it's not really a good use of your time. They just no longer use, they have long half-lives, they had a lot of issues, and so these second generation agents are still there, still being used occasionally, although again, like I said, less common. Glimepiride, Glipizide, and Glyburide. All right, now let's pivot over to indications and uses. All right, well, is anybody surprised? It's type 2 diabetes. It is an adjunct to underlying exercise and diet. That's simple, right? Makes it easy. All right, now moving on to our net benefit. Why would we pick this drug class, especially with so many other options available? Well, I mean, the reality, guys, this is a cost-effective option that has both history and experience and evidence. Now, is it the best option for patients compared to other treatment options that we now have in our toolbox? No. Why is that? Well, it served a purpose, and it still can serve a purpose, but its benefit is it can lower the A1C up to 2%. The downside is it doesn't stay that way. It's not sustained A1C reductions like with some of the newer drug classes that evolved beyond this. It also causes a progression of the disease by facilitating beta cell burnout. And so that benefit, especially nowadays as we understand the disease better and we have more treatment options, this one has fallen down, so that net benefit has lost its luster and value over time. But theoretically, is still something that can be used. All right, now we're going to migrate over and start to dive into the pharmacology mechanisms of action to make sense of why is that net benefit the way it is, and why has it changed over time? Okay, so these drugs, the sulfonylureas, stimulate the beta islet cells in the pancreas to primarily enhance insulin secretion. So it's basically making them be overworked, right? Never stop. The half-lives and the durations of these drugs are such that the pancreas is just constantly working. Now remember, let's pause for a second and think about type 2 diabetes and its underlying pathophysiology. Remember, they still make insulin. In fact, if you look at the insulin secretion compared to someone without type 2 diabetes, the insulin secretion is higher. And you're like, well, wait a minute. If it's higher, why are we giving them a drug to make it even higher? Well, because you're trying to overcome the insulin resistance associated with type 2 diabetes. And so you need more insulin to do that than what you would normally need. And so now the cells are already working hard to try to meet this metabolic demand, and now we give them a drug that comes in and just kicks them in the rear end and says, no, 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 you need to run faster and harder, and by the way, you're not going to stop. Well, I mean, anything's going to fatigue. You're going to wear it out, right? So how does it do that? How does it facilitate that insulin secretion? And that's what's outlined here. It's a ATP-dependent channels in those cells that get blocked by the sulfonylurea, and that depolarizes the cell and causes this calcium to come in, and basically it allows the vesicles that hold on to that insulin to fuse with the membranes and release the insulin into circulation, and it just does that continuously. Now, in doing that, you can also decrease hepatic glucose output, again, a little bit. Why? Because insulin then makes its way through the portal circulation and eventually will get into the liver and regulate some of that. So there's negative feedback loops on the biochemistry by insulin's presence to begin with, okay? And that's just part of it. So it can decrease some of the accelerated hepatogluconeogenesis and glucose production that is being that is happening as a result of the disease. Now, pharmacokinetics and dynamic applications. Glyburide in particular is one that you want to highlight, remember. It is the culprit for board exams and real-world practice issues. It is renally excreted, and so the risk of hypoglycemia with its already longer duration of action in somebody with impaired renal function is significantly greater. This is also true in patients with an inherent decline of GFR as they age, i.e. our older, elderly geriatric patient population. So just keep that in mind. It is an important nuance that you need to make sure you are familiar with, okay? All right, now moving on, we're going to start talking about some of the clinical application, and we're going to start at the high level of where do these drugs fit in the overall management of diabetes, but also compared to other drugs, right? So you should have that basic framework and structure in your mind so that you know when to pick one agent over another or why issues, we may stop one drug and start a different drug. That should make sense to you, okay? So I put together these tables that are available at thisiswhy.health for free download. The link to this lecture is in the description of the video at YouTube, or if you are visiting us and listening to us on our podcast channels at Spotify, Apple, Amazon, those kind of places, then the link is there so you can get access to these tables. But this is a general treatment strategy summary. Type 1 versus type 2. We're not treating type 1, okay, where they need insulin plus or minus pramlintide. Type 2, those patients are, yes, medical nutrition therapy, exercise, and then that first bullet is monotherapy or combination therapy with a non-insulin agent. Well, sulfonylureas are not insulin. They increase the release of insulin from the pancreatic cells, right? So but they're not insulin itself. Well, why does that matter, even drugs that mimic or secretagogues, as it relates to insulin concentrations? Well, it matters because of the risk of weight gain and hypoglycemia, which are things that patients don't want to experience, and we as clinicians don't want to have our patients experience. But when we start to dive in to those non-insulin agents, well, we're left with secretagogues and non-secretagogues, okay? So the secretagogues are meglitinides and the sulfonylureas. And again, I put together this table to highlight the mechanisms, but these are your secretagogue non-insulin agents. And again, the first generation agents are only here for reference. They have a longer half-life, longer duration of action, okay, just fell out. Second generation agents are the ones that we've been talking about. And again, they have a shorter duration compared to the first. That's really it, okay? But they are the drugs that are going to keep that pancreas functioning, whereas the non-secretagogue, non-insulin agents like amylin analogs, pramlintide, metformin, GLP-1 receptor agonist, tirzepatide, which is our GIP, GLP-1 agonist, and then our SGLT2 inhibitors and TZDs, all of those drugs, many of these drugs are designed and evolved, you see there's a lot of them for a reason, to not only try to get sustained A1C reductions by not progressing the disease forward, but also treating other comorbidities, weight, fluid volume problems, kidney disease, vascular disease. These drugs have helped fit in. And you can see where the growth has been predominant because you see the number of agents in those classes reflect that value, reflect the opportunity to make money, of course, but also options for treatment and where the evidence lies, okay? Now, I've also put together in this table, at the last table here, is what comorbidities do you consider using sulfonylureas or these drugs or not, right, avoiding. And if you look at the column with patients with specific comorbidities, you don't see sulfonylureas listed at all for things to consider. Like you want to purposely add on sulfonylureas because this comorbidity is present. That's not there. Now, this is my table. It's my interpretation of the totality of the story and the evidence and the issues with these drugs. And largely this is true. I'm not trying to, I mean, obviously I'm biased by my own opinion at some level, but it is a 30 years of history of my experience in seeing this, but also what the evidence kind of points to. So this can be very helpful, making sure you have that framework and that perspective as you're managing multiple patients who are diverse in their comorbidities, okay? Where should you avoid them? Well, in your obese patients or overweight patients, that's listed there because you're going to cause weight gain at some level, right? And we don't want to, do that in these patients. And that's really the main problem outside of hypoglycemia from a comorbidity standpoint, okay? From a comorbidity standpoint. Now, what about dosing, dosage forms, and these kind of things? Well, typically you take it with the first meal of the day to avoid nocturnal. So that's hypoglycemia occurring in the middle of the night, right? Then you need to titrate to the next dose until basically, you get that control that's needed. And then you might see that you have to continue to titrate because, remember, you're progressing the disease. And so you find most patients are on twice a day, typically for their adequate control and to get there. But the problem with these drugs is they're not used for type 1, they're only for type 2. You cannot use them also for DKA. I hope that makes sense. We don't give oral treatments. We're trying to, we use IV therapies to get DKA under control. So there's just issues with them, okay? And just be careful with that. Glyburide should also be avoided with Syntan for risk of hepatotoxicity, and that's just one of those little pearls, kind of star, keep in the background. All right, cardiovascular risk. The use in patients with cardiovascular disease is somewhat controversial. There's some evidence, maybe that there's some slight benefit. Again, treating the diabetes helps you to treat other aspects of the comorbidities that evolve from the uncontrolled diabetes. So there is some indirect benefit. But really, these drugs, when you now put them in the context of the other non-secretagogue, non-insulin agents, there's really no leg for them to really strongly stand on. Now, patients who end up getting bariatric surgery, okay, which is decreasing now that we have all these weight loss drugs. When you do that, you regain some of the basic sensitivity of the insulin, and you improve it, and you decrease caloric intake. So you want to back off on some of these drugs because of the risk of hypoglycemia, but you also don't want to facilitate weight gain in somebody who's trying to lose it. And so that's why that risk was there. The risk of hypoglycemia is high with these agents because they work longer and don't stop, okay? And so secretagogues end up putting you at greater risk for that and weight gain. I think I've already mentioned that multiple times. Now, think about the name of these drugs, sulfonylureas. Why in part does it get that name? Well, because of a sulfa group that is on there. But not all sulfonamide containing medications carry the same allergy concerns or risk. Like when you think about sulfa allergy reports by patients, there's a concern for cross-reactivity. Most of the time we're talking about Bactrim and sulfamethoxazole specifically, right? And so they're not the same. Well, why is that the case? Well, this diagram, again, It shows the image of sulfamethoxazole. This is the chemical structure of sulfamethoxazole because it is the classic agent to compare things to. But antimicrobial agents that contain sulfonamides are different in their structure than non-antimicrobial sulfonamides. You don't need to memorize this. The point is to explain why the cross-reactivity is not what it is, or what is the degree of concern that you should have for it. So when you look at the sulfonamide moiety here in this structure, again, this is available at thisiswhy.health for you. The sulfonamide is this highlighted area in this shaded green, right? But what's important about that sulfonamide that makes it allergenic, creates the adverse responses that we see in many of the antimicrobial sulfonamides, has to do with the N4-arylamine and N1 substituent. There are two rings in the orientation around the sulfonamide. That is important because drugs that lack those N1, N4s groups, they don't have that same cross-reactivity. They don't cause that same degree of allergenicity. That doesn't mean it doesn't cause it never. Everybody, if you look in a product package insert, has side effects, and rash is always listed there. Like, why? Who? Well, that just happens sometimes, right? But the reality is that it's not. So what I've tried to put together for you is the sulfonamide-containing medications table. On the far left are the sulfonamide antimicrobial drugs, classically sulfamethoxazole, right? But there's also antivirals, antiretrovirals like darunavir, fosmanpiravir that fit in there. Those cross-reactivity between those agents in that column is higher. You should most certainly avoid that. But if you look to the right, there's the sulfonamide non-antimicrobial agents. And there's a lot of drug classes listed here. COX inhibitors, carbonic anhydrase inhibitors, you got the anticonvulsants, even statins, rosuvastatin in particular, loop diuretics, thiazide diuretics. They're all here, but sulfonylureas are listed here. But remember, they lack that same orientation, so we don't see the same cross-reactivity. That doesn't mean you ignore it. It doesn't mean that you never think about it. It's just the risk of cross-reactivity is significantly different and lower because of that. Those side groups around the sulfonamide are not the same. Okay? All right, moving on to special populations. Pregnancy, Glyburide may actually have some efficacy in this. It has been studied. You probably shouldn't do that in general. You should obviously consult with an OB physician or provider before doing that. Can talk with the patient and share decision-making and risk and benefit, especially when compared to insulin, because you really need good control. So there is some evidence with Glyburide there. What about geriatric or elderly patients? Well, remember, their GFR goes down as they age. And so drugs like Glyburide in particular can be a problem. They start to accumulate it. Seen this 100 times, man. It's classic. And so you want to be very careful in these patients, especially when they're not eating right, or they're dependent on other people to feed them, and they're just keep getting medications. Unfortunately, I've seen this in nursing home, long-term care environments where patients are largely neglected. They're just being given medicines, and someone puts a tray of food in front of them, but they can't eat, or they can't feed themselves, and no one's doing it. And so they're taking medicines, but they're not then eating. That's not a good solution, right? So patients come in all the time with altered mental status and things. We have to think very broadly in these patients, but one of them is check a glucose quickly, right? And it's even one of the drugs that makes it on the Beers list, which is an established list of medicines that raise the concern of adverse drug events in our geriatric patient population. And so please respect that component in your older patients where they're dependent on us to use the right drug in the right scenarios appropriately. And then kidney disease, obviously, Glyburide is going to be one of your problems. Now, moving on to monitoring parameters. Yeah, the A1C at baseline every 3 months until you get them under control is necessary, and then you can start to stretch that out. But don't sit on these patients. Remember, they end up getting decent reductions in A1C, but you got to periodically check it because remember, they could facilitate the progression of the disease, which is one of the reasons why we don't see them as used as first-line agents many times. But you want to get a basic metabolic profile, CMP to check the creatinine, especially if you're on Glyburide, right? You get a glucose with it, that helps. But these patients should be monitoring, they're doing their self-monitoring blood glucoses, especially so they don't develop hypoglycemia, because the way they're going to need to treat it is going to be important, especially knowing that these drugs stick around for a long time. All right, guys, that wraps up sulfonylureas. I hope it made sense, brought things together. We still have a few agents. There's still a small, maybe potential role for them, but when you look at them in the context of other drug classes, it's hard because these are secretagogues. They increase that release of insulin and they can progress the disease and they can cause risk of weight gain and hypoglycemia. It just makes it hard when we have other options. But there is evidence, there is history, and so, you know, it is cost effective in that sense, as long as they're not having adverse outcomes. Okay, thank you so much for joining me. Again, please, if you haven't done so, you know, try to subscribe on YouTube to our channel. Really appreciate that. If you, especially a like, some comments. We welcome your feedback. We welcome your clinical pearls. This is how we all learn from each other, guys. This is about helping each other learn why we do what we do so that we can help each other as we manage patients who are diverse and need our help. So thanks so much for joining me. I'm Dr. Busti, and we'll see you next time. Take care. Bye-bye.